Good afternoon. We're going to get started with the afternoon session. And we're trying an experiment this year. I'm president of the Ogden Surgical Medical Society, and I'm also the chairman of the Medical Review Board for our local affiliate for the National Kidney Foundation. So we're trying an experiment this year of combining the two organizations for an afternoon session related to kidney disease. So we have 4 lectures this afternoon regarding different aspects of kidney disease. If you'll notice on your desk, you have a folder from the National Kidney Disease Educational Program, which helps you and your patients in terms of giving them some information about chronic kidney disease. And then in the envelope is a GFR calculator, which was provided by Health Insight, because they have some programs regarding treatment and evaluation of chronic kidney disease. So feel free to take these and use them in your individual practices. Our first speaker is Andy Narva. He is director of the National Kidney Disease Educational Program in the National Institute of Diabetes and Digestive Kidney Disease. And he was previously the chief clinical consultant for nephrology and the director of the nephrology program in the Indian Health Service. And I've known him for at least 10 or 15 years when we've served on the medical review board for our end-stage renal disease network. And you can see the title of his talk. Some of us are from Mars and some of us are from Venus, and he's going to try to help resolve the differences.
Good afternoon. I'm really glad to be here. I didn't know until a few days ago that this was such an old and established medical conference. Harry told me it's the second oldest west of the Mississippi, the oldest west of the Mississippi. And so I'm very honored to be here, and the faculty you have is quite impressive. I do have 2 strikes against me, though. One is I'm talking right after lunch, and about halfway through my talk, I think the postprandial somnolence will probably set in. So hopefully not too many of you will fall asleep. And the second thing, the more major thing, is I'm talking about kidney disease, which is a tough area for most physicians. And I think that most physicians spend most of their careers in recovery from the second-year renal block, and they never quite get over it. So hopefully we can address some of that and help us all make some progress. So I'm going to talk a little bit about the standards of care for people with chronic kidney disease, how we're doing in implementing that care, some barriers to improving care, something about identifying and monitoring people with CKD, some strategies for improving chronic kidney disease care in the primary care setting, collaborating with a nephrology consultant, which may be easier in Utah than it is elsewhere, because I've yet to meet a nephrologist from Utah who wasn't superb, but that's not true everywhere. Superb and also very collaborative. And then I'm going to describe some of the materials that our program has developed, which are available to you for free. So there are a number of guidelines in chronic kidney disease, as there are in other chronic diseases. And if you look at these from the United States, from the Kidney Foundation, from the National Health Service in England, from Australia and New Zealand, and basically they all sort of agree on some basic performance measures. One is that when prior to starting dialysis, patients should have at least 6 months of sort of integrated care where they get patient education, nutritional counseling, and they're fully informed so that when they start dialysis, they know what it is to expect and they can make informed decisions, that they should be counseled to decrease their cardiovascular risk, that They should have excellent blood pressure control, that their bone and mineral disease should be controlled, anemia should be addressed, and this is changing. They should be immunized against hepatitis B. They should be on an ACE or an ARB. And ideally, they should be assessed for transplant and referred even before the initiation of dialysis, if that's possible. And finally, for people who do end up going on dialysis, at the time they start dialysis, they should have a functioning fistula, or if they're going on peritoneal dialysis, they should have a Tenkoff catheter in place so they can have a smooth transition. So how are we doing? Well, there are a number of kidney measures which were included in Healthy People 2010. Are most people here familiar with the Healthy People document? Okay. The Healthy People document is a document that the Public Health Service produces every 10 years. And it has a large number of health measures that are designed to improve the care of people of the United States. And includes everything from immunization rates to diabetes care to cardiovascular disease prevention. And it's important, even though even those who've heard of it haven't read it, it's important because if you're trying to get federal money allocated to a problem, you have to base it basically in some level back at that on this document. So it's a document that's produced every 10 years with the goals for the following 10 years. So Healthy People 2010 was published in 2000, and for the first time it had a number of measures that related to chronic kidney disease. And this is a big step because it's a long way from childhood immunizations to a lot of the things that we do for people with chronic kidney disease. But the first measure, and these have been monitored over the last since 2000, were that people with kidney disease and type 2 diabetes get some pretty rudimentary care, which is just 2 hemoglobin A1Cs, a lipid measurement, and an eye exam in the previous year. And the goal was 36%, which is a pretty low bar. But even with that low bar, we only got to about 30% in 2006. The goal was to have as many people as possible with diabetes and kidney disease have an ACE inhibitor or an ARB. And although the rates are about 70%, they haven't changed over the whole period since 2001. A very important measure is blood pressure control, which is probably the single most effective measure that you can implement to slow the progression of kidney disease. Lowering blood pressure slows progression at any stage of kidney disease, and it's likely to really have a major effect, especially if it's implemented on a population basis. Well, what we've found out is that even with people who've lost a significant amount of kidney function, who are hypertensive, 25% of those folks were not even aware they had hypertension. About 7% were aware but not treated. About 50% of people were aware and treated but weren't controlled, and only about 20% of people had controlled hypertension. So this isn't something that requires exotic or cutting-edge technology. This is a basic goal that we all share, and we're not doing well there. And that's probably the single most effective intervention. Finally, there was a measure addressing preparation for dialysis, including counseling, nutritional care, education on treatment choices, and management of cardiovascular risks. And you can see that, first of all, a third of patients met the nephrologist at their first treatment. So they met the nephrologist presumably in the emergency room as he or she is inserting the catheter in their neck. But to me, what's even more disturbing is in the kidney disease guidelines, and as in all the guidelines, there's a huge nutritional component. You know, they all talk about how important it is to get dietary counseling. Well, and dietary counseling is very effective in kidney disease. But you can see that only 13% of people starting dialysis ever saw a dietitian prior to starting dialysis. 13%. Anemia is not well treated. And what's interesting here, because a lot of what you'll hear from the kidney community is that the answer is early referral. Send your patients to the nephrologist early. Well, even patients who were followed by a nephrologist for more than 12 months, more than 30% of those patients started dialysis with a hemoglobin under 10. This is data collected at a time when we were treating everyone with EPO. We're a little bit more ambivalent now. But still, the answer obviously isn't just referral to a nephrologist, because that many people don't get there. And also, the final measure that I'll just describe to you is the proportion of patients who have a fistula in place at the time they start dialysis. Now, this may seem like an obscure measure if you're doing primary care, but this is very critical, because in order to have a fistula in place at the time you start dialysis, that means you had to have the procedure done several months before you start dialysis, which means several months before that, someone had to talk to you about treatment options, which means several months before that, someone had to tell you you actually have chronic kidney disease and you're headed towards dialysis. Well, who's taking care of those patients in that 1 or 2 years before they reach end-stage renal disease? It's the primary care community. And so patients aren't getting that kind of counseling, and about 80% of people start dialysis with a catheter. Well, they eventually can get a permanent access, but it's a problem for people to start dialysis with a catheter because that's prone to infection and clotting and a number of complications related simply to dialysis. But beyond that, it's also associated with a sort of an inflammatory state, which we think plays a large role in the very high death rates that we see in patients who start dialysis and who die within the first year. So avoiding those catheters is very critical. So from all this, you can see that defining optimal care really isn't the problem. We know what people are supposed to get. The problem is getting that care to the people who really need it. We know that for people who don't get appropriate care, they progress more rapidly, they are in worse health status when they start dialysis, they have a higher mortality after they go on dialysis, and they're less likely to get transplanted. There are not a lot of large-scale studies that have shown the effectiveness of intervention, but there are a few, and most of these are sort of small. But we know that CKD education delays the time till dialysis needs to be initiated, increases fistula utilization, improves survival, and decreases hospitalizations. Those are all good things. So we know what we want to see happen, and we have some ideas of how it should happen, but there are not a lot of models of how it's done. And that's been a big problem. The Renal Physicians Association has a CKD patient management toolkit. They're just testing it now, and it's mostly meant for nephrologists' offices. The one model I'm going to talk about at length is at Kaiser Permanente in Southern California, and I'll mention my experience in the Indian Health Service and what we were able to accomplish. So Southern California Kaiser Permanente is a large HMO, about 3 million patients. They've had routine reporting of estimated GFR since 2003. I assume everybody here gets an estimated GFR reported with every creatinine. Is that correct? That's the right answer. Good. What they did, though, because there's a problem with getting the estimated GFR, because you end up identifying a lot of people who are not at risk of progression. And if you're a busy primary care provider and you have limited additional resources or maybe no additional time, you want to know who's at greatest risk of progression. So they modified the staging system that you may be familiar with into a high-risk and a low-risk group, so that for people with GFRs between 30 and 60, if they had proteinuria more than 300 milligrams per day, or diabetes, or their estimated GFR plus half their age was less than 85, and that's there to eliminate people who just had an age-related decline in GFR. That was the high-risk group. The low-risk group were people who had GFRs between 30 and 60 who didn't have any of those characteristics. And so you can see they had a lot of patients. They had about 72,000 patients who met the criteria for chronic kidney disease. And in this stage 3, which is the largest group, they had 55,000 people with this high-risk status. Now, the important thing about making this distinction and bringing a few more factors in than just estimated GFR is that they had an almost equal number of patients with GFRs between 30 and 60 who didn't meet those criteria and had chronic stage 3. So those patients were not targeted for population management. So in other words, what they did was they eliminated almost half of this potential population from systematic interventions. And that's important because everyone has limited resources and limited time. And they focused on people who are at greatest risk of progression. And those are the people with diabetes or proteinuria or more than an age-related decline in GFR. They also have easy access to nephrology referral. It's an HMO, so there was no additional cost. They have lots of nephrologists. There was no disincentive for referral. And there's a culture of referral in this integrated system. And in fact, most of the patients did end up seeing a nephrologist. The guidelines for referral were that for patients should be referred if their GFR is less than 30 in general, but if the GFR is greater than 30, to not refer unless they met some other criteria, such as high-grade proteinuria, refractory hypertension, a need to biopsy to make a diagnosis, or an unexplained acute change in GFR, the kind of things that alarm any of us and prompt referral. So if you look, you can see that the patients who needed to see the nephrologist generally did. People with stage 5, which is a GFR less than 15, 89% had seen a nephrologist, and that's much higher than the data I showed you earlier. And stage 4 was 77%, and stage 3, about 21% had seen the nephrologist in the last year. But what that means is most of the care was delivered by the primary providers and as part of general medical care. 85% of the visits were to primary care providers, and remarkably, they were able to code those visits for CKD, which is a major problem in kidney disease because many visits don't get coded, and so we have a hard time identifying what the burden of disease is. They have a computerized system which provides patient-specific information and advice, as well as summary sheets and even what they call decision support, reminders of algorithm-based interventions, the kind of thing that we're all coming to use. But they've had an EHR for quite some time. So what difference does all this make? Well, if you look at all of the patients with CKD, you can see that about 44% of patients had blood pressure control, which is much higher than the data I showed earlier. That 80% had had an urine albumin measurement in the last year. That about 84% had been on an ACE and ARB, and that there was good monitoring of their lipid status. For people with advanced kidney disease, and these are patients with GFRs less than 30, 86% had had their anemia monitored, and only 12% had a hemoglobin less than 11. Hospital days were reduced, and about 77% of patients had seen the nephrologist in the last year. You know, what's really interesting to me, though, is despite this really great system, almost 2/3 of the patients never attended a class on dialysis prior to starting dialysis, which suggests that one of the big barriers is helping the patient get to the point where they can accept their diagnosis. So the outcome measure that they used, though, was something called optimal start. And what that included is people who reached the point of dialysis where they either started directly on peritoneal dialysis, which requires quite a bit of preparation and would be a sign of good care, or people who got a transplant before they even reached dialysis, which is another sign of good care, or who started dialysis with a functioning fistula in their arm, which again can only happen if someone has received long-term excellent care of their chronic kidney disease. So that may be about as good as we can do. So about 54% of patients had this optimal start. And this is something you may hear more about because this is a term which may be part of the new QIO scope of work, if you're familiar with the projects of the quality improvement organizations. The one in Utah, who we've worked with quite a bit, is excellent, and I'm sure they'll make sure you hear about it as that program expands. So again, defining optimal care isn't the problem, getting it implemented is. And there are two issues which need to be addressed if we're going to make some progress. One is that there are real disparities in chronic kidney disease. African Americans have about 4 times the rate of dialysis as Anglos. I use that term Anglos in the East. They don't know what I'm talking about. I think they think I'm talking about British people. The American Indians have about twice the rate. These are national numbers. Hispanics and Asians also have increased rates. But the second thing that's really key is what's driving the increase in chronic kidney disease is diabetes. It's this blue line here. And you can see that's the one over the last 20 years that's really, really gone up. Cystic disease and glomerulonephritis are pretty flat. Hypertension has been pretty flat for a while. It's diabetes, and mostly type 2 diabetes. So the phenomenon that we saw in the Indian population during my career in Indian Health Service now affects everybody, including now in Utah, which does not have a large percentage of racial minorities, but is still experiencing this. And this is happening in other states where with the same phenomenon. West Virginia and Virginia and Vermont are now seeing lots more diabetes and all the complications. So the way Medicare looks at this is, here are the patients with CKD, here are the patients with hypertension, and here are the patients with diabetes. Almost all the patients with chronic kidney disease have diabetes and hypertension, and it makes sense that we should address chronic kidney disease in the context of addressing those diseases as well. So the paradigm we're trying to move towards is sort of diagrammed here. This is kidney function here, and this is time. And generally, this black line just shows how most people with chronic kidney disease lose kidney function at a pretty constant rate. Kidney disease is progressive, and it's irreversible in general. And what's traditionally happened is that nothing, really, until we get down here where the creatinine gets to a level where someone gets really alarmed and they send the patient off to the nephrologist or something else. And the kidney function, something's done, and kidney function continues to decline, but at a slower rate. And you gain this much time before you reach this gray area, which is kidney failure. What we're trying to do is to move this point up the curve here so that patients are identified and interventions are done earlier in the course of disease. You're not going to arrest kidney disease, but you can, if you start slowing it down way up here, you gain a lot more time, and many patients may never reach end-stage renal disease and may never develop serious complications if things are addressed up here. But who's taking care of them up here? With GFRs are nearly intact. These are patients in the primary care setting. By the time the GFR gets to 60 or the creatinine gets to 2 or 1.5, the game is in large part over in terms of prevention. You can do secondary prevention, but the greatest opportunities to make an impact on the burden of chronic kidney disease are when the patients are being followed in the primary care setting. So what are the challenges to making that happen? Well, a lot of patients don't get diagnosed. It's taken 10 years to have the routine reporting of estimated GFR implemented nearly universally. The implementation of recommended care is poor. We have these guidelines, but for those of you who are general internists or family docs or nurse practitioners, you have guidelines on everything. And I could give you an incredibly inspiring talk right now, which I'm sure I am, and you could go back, but and if you have a handout from us, then you'll put that on your desk, but it goes right on top of the congestive heart failure guidelines, underneath the asthma guidelines that are coming tomorrow. And on Monday you're going to get screening for domestic violence in the primary care setting. And there's no way that you can implement all of those things in the 11 minutes you have with your patient. So We have these beautiful guidelines that are all the size of a phone book, and they're just too much to deal with. And then in kidney disease, there's a particular problem with clinicians really not feeling comfortable with kidney disease. And as I think for a lot of people, it dates to medical school. And the kidney block was terrifying because it just enhanced their sense of inadequacy, because the physiology is really complicated. Oftentimes the teaching isn't that great. And they finish the block and they go like, I hope I passed that block. I never want to see that stuff again. And then as you go through training, the patients you see are sick, and the nephrologist is telling you not to touch them. Don't draw blood. Don't give them any meds until you talk with me. And it tends to, and then the patients go on dialysis and they're treated over there. They have a separate reimbursement system. Everything is different, and they're just sort of separated out of the system. And it leads to the idea that chronic kidney disease is over there. Everything else is over here. And we haven't really done much to take that fear away. Congestive heart failure, a diagnosis of congestive heart failure is probably much worse prognosis than having a GFR of 30. But most people would be happy to manage that patient in their office and won't refer to a cardiologist unless something is really hard to figure out or the patient doesn't respond to therapy. But kidney disease, it's like, oh yeah, let's get this patient out. So I think we need to think about these patients in a different way. So for all these reasons, the program that I direct at the NIH was developed about 10 years ago with the goal of reducing the burden of kidney disease by early detection, but also not just trying to identify the maximum number of people with kidney disease, but to identify those patients at greatest risk so that we could focus our intervention on them. Promoting evidence-based interventions, and there aren't really very many evidence-based interventions in kidney disease. There's a lot of observational data. We do a lot of things that aren't evidence-based, but what is evidence-based is very limited. And then in the last few years, we have taken a novel approach in trying to get the different agencies that take care of chronic kidney disease to talk to each other. What we're basically doing is trying to bring what's called the chronic care model to chronic kidney disease. And I'm not going to go into the details of this except to say that the chronic care model is a sort of a paradigm for systematic change in chronic care, which has been shown to reduce disparities in chronic disease. And kidney disease has huge disparities. And so even though this is old hat in diabetes and asthma and depression, this is a relatively new thing for kidney disease. So what can primary providers do? Well, you can recognize these patients by getting an eGFR, an estimated GFR, and an albumin measurement on them. You can screen for complications. You don't have to necessarily treat it, which basically means, in addition to the SMA7 you get every year, get a calcium, phosphorus, albumin, and a CBC. Treat them for cardiovascular risk, and try to get some nutritional counseling. That's a challenge because many practices don't have a dietitian on site. But the most radical thing that you can do is actually to talk to your patients about chronic kidney disease, to tell them they have it, to tell them that it's progressive, that even if they do everything that you tell them to do, it's still going to get worse, but it'll get worse much more slowly. And if it looks like they're a progressive disease and they're going to live for a while, you could mention that someday they might need dialysis. You're not wishing that on them, but it's out there. So I want to talk a little bit about this identifying and monitoring. And I'm going to talk a little bit about estimated GFR, albumin-creatinine ratio, and a little bit about staging. Chronic kidney disease is defined, has been defined by a group at the Kidney Foundation. It's pretty widely accepted that 3 months of either decreased kidney function with an estimated GFR less than 60, or sign of kidney damage, which generally means proteinuria. So GFR is a pretty important measure. It still brings back some of these memories from the second-year renal block for a lot of folks. And if the providers don't understand it, then they can't use it to help educate the patients. So the way I explain it to patients is that the GFR, the kidney is a filter. It's not one big filter like the oil filter you put in your truck. When I say that to my patients in Washington, they look at me like they don't have trucks. But anyway, so each kidney is made up of about 1 million filtering units, and we can get an estimate of the health of that kidney by looking at the filtration rate. And if we know the filtration rate is 50%, then probably 50% of those filtering units are working because they tend to drop out one by one. And we can't measure it directly. So how do you get a sort of intuitive sense of what a normal GFR is? Well, cardiac output is about 6 liters per minute. About 10% of the cardiac output goes to each kidney, so that's about 1.2 liters per minute. What gets filtered is the plasma, not the cells, and so that's 50% approximately, so that's 600 milliliters per minute. Now, all that plasma can't go through the glomerulus because that would leave 100% cells on the blood vessel side, and the blood wouldn't flow. So only about 20% does, and so that's where you get to a normal GFR of about 120 milliliters per minute. So the estimated GFR is not the GFR. And, there's initially when this is being introduced, there was a lot of pushback, and people said, I have this 86-year-old guy, he's got cancer, he weighs, 37 pounds, his creatinine is 0.3, and his estimated GFR is 180. And, I know we want to dose him for some chemotherapy, we know we can't use that. So this isn't working, and we're going to dump the whole thing. Well, he's right. In that setting, you can't use it. What the estimated GFR is an estimate of the GFR. And what people don't understand is that it's a population. It was derived from a population of people with kidney disease. So it's the best fit for a large population. And if you plug in the variables, which are age, race, gender, and creatinine, you'll come up with an estimated GFR. And it is a very good estimate of the average GFR of 100 people with that age, race, gender, and creatinine. But in fact, for any individual, their actual GFR will be distributed around that. It's kind of like the estimated date of confinement. If you know someone's last menstrual period, you can predict the most likely date that they'll deliver. But only, I think, 17% of women deliver on their due date. They deliver plus or minus 2 weeks. It's the same thing. It's a guess. It's an estimate. And if you plug the numbers in and they come out and they don't look right, that's why we went to medical school or nurse practitioner school or PA school. It's to use some judgment. So it's an estimate. It's also can't be used in people who don't have stable kidney function. And if someone has acute renal failure, which they had sustained an injury yesterday, and they come in today and they've had no kidney function for 24 hours, their creatinine, if it was 1 yesterday, it'll be 2 today. It's not going to be 12. And if you plug that 2 into the formula, you'll get an estimated GFR of some value, but it has no bearing on what's really happening because their GFR is actually 0. So you have to have a stable creatinine. So I'm going to talk a little bit about proteinuria as well, because proteinuria is extremely important and less attention is paid to it. It's essential to diagnose people with CKD. About 40% of people diagnosed with CKD have just proteinuria. It's a very good marker for prognosis, especially in diabetes. It's a marker for cardiovascular disease. It's probably a good surrogate outcome, especially for diabetic nephropathy, which means if you lower the proteinuria, you're improving the patient's outcome. And it's also a really good tool for patient education. If you can tell someone how much protein's in their urine, they can use that information for self-management the same way they can use hemoglobin A1C or estimated GFR. So the idea of routinely checking urine albumin has been a tough one to sell. And one of the main problems is there's about 1 million tests which measure urine protein or urine albumin in one way or another. And in fact, that's just a partial list that I found in Indian Health Service of all the different tests that might be used. And some of them include just a dipstick for protein, some just a dipstick that includes protein and creatinine. Others are 24-hour urine measurements, and so on. But the standard test is going to be the urine albumin creatinine ratio, and you may be familiar with this. How many people are familiar with this? I assume most of you. How many people can explain it? If there's a number of 786, what does it mean? So that, I won't ask anyone to raise their hands because most people can't explain it. They do it. I did the microalbumin test. But they really can't. They go like, so it was 2,864. So what do I do now? Do I get 24-hour urine? And do you get this question? I did. So really, what this is based on is the idea that creatinine and albumin are both excreted at more or less constant rates throughout the day. So that if you take a spot specimen, the ratio between the two will be the same in that spot specimen as it is for 24 hours. So that's terrific. So why does that tell you anything? Well, it tells you something because in 24 hours, most people put out about 1 gram of creatinine. So the ratio then is equivalent to albumin excretion in grams in 24 hours. What it usually comes back as milligrams albumin per gram creatinine, which is equivalent to milligrams per day. So the way that's been also reported has been whether it's microalbuminuria or macroalbuminuria. So the normal has traditionally been less than 30 milligrams per day. Microalbuminuria has been 30 to 300, and macroalbuminuria is greater than 300. There's no physiologic meaning to this distinction. You either have albuminuria or you don't. The 300 really is the level that was picked up by the old dipstick, which we always used. And there were a lot of studies which when the first measurements of low levels of albumin came in, that talked about people who were dipstick negative, but they had more than 30. And so that's where that term microalbuminuria came from. But there's nothing magic that happens to people when they cross that threshold of 300. It has no physiologic meaning. So it's a continuous variable. 350 is worse than 250, 250 is worse than 150. So the other issue where there's a lot of pushback is people say, well, I did the microalbumin test last year, and it was positive. And I put the patient on an ACE inhibitor. Why do I need to keep checking? Why do we need to do it again? And the reason is that urine protein or urine albumin is a very good marker for prognosis, and in diabetes at least, it's a very good surrogate. So in other words, if you look at response to treatment, let's see here. If you look at response to treatment after starting renal angiotensin system blockade, and this is the greater reduction in albumin, versus a renal endpoint, look here, versus the risk of going dialysis, you can see that the greater the reduction in urine albumin that you see in response to putting a patient on losartan, the less likelihood that they're going to progress onto dialysis. So in other words, if you can say to a patient, you had 1.5 grams of albumin last year before we put you on lisinopril, and now it's half a gram. I think there's a lot of good evidence that means that we've delayed the injury to your kidney, and it's occurring more slowly, and your kidney is really doing better. If someone has proteinuria and doesn't respond to one dose of lisinopril, it might be a reason to increase it. So it's a very good tool for helping the patient understand what's going on. Finally, I want to talk about staging. This is the staging system that has been promoted by the Kidney Foundation, and it's based entirely on GFR here. And the problem with this is that you see that it includes GFRs above 60 for stages 1 and 2. Well, the equation we use to predict GFR isn't really accurate above 60. So that's why it should be reported in your facility as greater than 60. There's also, you end up identifying a lot of people who have just an age-related decline in GFR who aren't going to progress, and that's not helpful. And then a significant proportion of patients have GFRs that are above 60. So it's probably too narrow a basis on which to make a diagnosis and prognosis. It's just not that helpful. So even the Kidney Foundation has recognized this and had a meeting about 9 months ago to look at adding other measures. And one of the measures that definitely needs to be part of this is proteinuria. And there's a recent study published in JAMA, which was a very large cohort of patients followed in the community. And basically what they showed is that the risks at any given level of GFR, the risks for a cardiovascular event or a kidney event were independently associated with the level of proteinuria. And for example, you could look at two patients, one with a GFR less than 60 and 400 milligrams per gram of albumin. That's stage 1, versus a patient with a GFR of 50 and a urine albumin and less than 30 milligrams of albumin. Actually, the person with stage 1 disease is at much greater risk. So obviously, we need something more than just the GFR to identify patients. So something will change. Perhaps stages 1 and 2 will go away. We'll probably, having these stages numbered kind of promises more than it delivers. It makes it seem like this is cancer, and it has real meaning between stage 1 and 2 and 3, and there's not that much there. It's likely, I think, based on epidemiologic research and long-term cohort studies, that we'll have some kind of scoring system, the same way we do for cardiovascular disease, which includes a number of factors, but probably it'll include diabetes status, urine albumin, blood pressure, and eGFR. And for that reason, my program doesn't really promote the staging per se. So I just want to show you some of the materials that we have. I still have a couple minutes, don't I? Okay, good. Which we have developed. Now, there's a lot of materials out there, and we don't have that big a budget, and so we've tried to focus on materials that don't duplicate what's there. And we really try to focus on things that are one page and that are simple. They need to be simple not only for the patient, but for the providers. And so this is the first thing that we did, was to develop a one-page explanation of urine albumin creatinine ratio. And on the back of that is an explanation of estimated GFR. And I think all of these are on our website, which is right here. And then we developed a tear-off pad, which you have, which explains GFR at the 4th to 6th grade level, and then explains urine albumin at the 4th to 6th grade level. And, we think that if patients know about these numbers, it'll help them take care of themselves. In the same way, knowing what their blood pressure is and knowing what their hemoglobin A1C is. And on the back of that, it's a tear-off pad. On the back of that is some general advice on how to protect your kidneys. And since it's from the NIH, it's 100% true. On the back of the pad, though, if you turn it over, what we did was we tried to distill down to 4 simple points that could be covered on chronic kidney disease that you could tell the patients. And we even gave 3 or 4 sentences that could be used to address these 4 points, which is what is kidney disease, what are the tests, and that kidney disease is progressive, and then what about dialysis and transplant. Now, if I could give you a program for patient education that would extend each patient visit by 25 minutes, and that's never going to get implemented because you don't have 25 minutes. But, if you could cover one of these points, you could even use these sentences to start with until you get comfortable with it. You might extend the visit by 90 seconds. But over time, you could cover all 4 points. It's not going to give the patients an exhaustive knowledge of CKD, but it's better than what they're getting now, which is in general not much of anything. We then now have developed an 8-page brochure for giving to patients, really. Now that you've told them they have CKD, it's like, what next? And so this is just meant to explain the basics of CKD. It's meant to be at a 6th grade level, and explain the mechanisms and what the tests are, and how some rudiments about diet, and addresses some common problems. Do I have to drink more water or less water? What about soda, alcohol, so on? And then tracking their results, and we include on the last page a little card where they can fill in their results, which are blood pressure, GFR, urine albumin, and A1C, if they're diabetic. Then we have developed a number of materials for dietitians. There's very few dietitians who don't work in dialysis units who are comfortable with kidney disease. They're just as afraid of these patients as everyone else. So we've tried to develop some materials for general practice dietitians that can be used by them to talk to patients with kidney disease. And also in the vast majority of primary care settings where there is no dietitian, another healthcare provider can use these materials to at least give some rudiments of dietary instruction, because there is no renal diet. I mean, the diet has to be individualized for each person, and I'm sure all the nephrologists here have seen patients with GFRs of 55 who've been told to cut back on their potassium, even though they have no problem with potassium. So the interaction results in them not eating fruits and vegetables, and eating a much less healthy diet, even though they don't need to, but on the advice of a healthcare professional. So anyway, that's, the dialysis diet is not the renal diet. So what this does is this goes over, it lists, and this is used in dialysis units as well, something similar. It lists lab tests, and it lists here's a place to put the results, and this is a simple explanation. And to go along that, we have a little, guide for the provider, which is only 10 pages, which is much shorter than anything else you'll find out there, which just goes through some general, this is for the providers, the general information about CKD, and then focuses on explanations that will help you use that report card in terms of assessing kidney function, controlling blood pressure, and then dealing with the complications. And all of this stuff should be available on our website. If it's not there now, it will be soon. So finally, what about nephrology referral? Well, there are a number of reasons to refer patients to a nephrologist, and these are similar to the ones that were in the list that I gave you earlier with Kaiser Permanente. There's a consensus on when patients should be referred, which is in general when the GFR is about 30. I'm not a big fan of automatic referral at any particular GFR. I think these patients need to be treated individually. Some people need to be referred when the GFR is 55. Other people will be at 30 for the next 10 years and don't necessarily need to go. The other question is, in the literature, the dichotomy is early referral versus usual care. And since usual care is nothing, early referral looks like the way to go. But what you don't see often is early referral and care by a nephrologist versus intervention in the primary care setting in a coherent way. And I think many of the things that need to be done, most of the things that need to be done for people with chronic kidney disease are very similar to what needs to be done for diabetics and hypertensives. Blood pressure control, ACE and ARB, glucose control. And it's not till people have very advanced disease that a lot of specialized interventions need to happen. So I won't stand up here and tell you should refer at a certain GFR, but I will tell you that it's important to have a good working relationship with the nephrologist and to send the patient with appropriate information so the nephrologist can really help those patients. And you need to provide history that gives some idea of what the rate of progression has been. So we have one more tool, and this is on our website, and this is what they call a fillable PDF. So in other words, you can bring this up on your screen, but you can enter results and then you can print it out. And this goes over, this is one page, the basic information that most nephrologists would like to see. Here's the reason for the referral. But here's information on how long, if they've had diabetes, how long, whether they have proteinuria, retinopathy, other complications, how long they've had albuminuria, a couple of serial GFRs because how things have progressed in the past predicts how they'll progress in the future, their blood pressure, additional studies, and these aren't required studies, these are commonly obtained studies. And if they're done by the time the nephrologist sees the patients they'll have a much more productive first visit. And then finally down here is assessment of the patient's knowledge, which includes, does the patient know they have kidney disease? Does the patient know the severity? And does the patient know they might need to go on dialysis? It's really not fun to tell someone that they have kidney failure and they're going to have to go on dialysis next month, and they appear to be surprised. Now, some patients have been told, but some haven't. So knowing that is certainly helpful. So why do I think what the advice I'm giving you is going to work? Well, I'm just about done. I worked for the Indian Health Service for 25 years, and Indian communities in the Southwest have the highest rates of treated ESRD in the world. And I was the nephrologist. I didn't take care of all the patients with kidney disease, but I was the only nephrologist in the system. And we did this where we made CKD part of primary care, and we found that changing patterns of care, though, required changing the system of how you did things. That a lot of the implementation came from non-physician professionals, that one of the best ways to do this was just to alter the diabetes care delivery system, not have a whole bunch of renal clinics. You can get at least half the patients, and in Indian population even more, by just changing diabetes care. And by emphasizing not referral so much as making sure the patient got what they needed. And as a result of those interventions, this shows the incident rates of ESRD due to diabetes over the last 20 years. And you can see here, this is the American and Indian population. And you can see that the risk of progressing to end-stage renal disease has decreased by more than 30%. Now, I can't tell you that's because of what we did in Indian Health Service. But if you want to believe that, that's okay with me. So to improve the care of people with chronic kidney disease requires changing clinical practice. It's hard to get people to do things differently. Presumably, we're all scientifically trained and we respond to scientific evidence. But we've got to improve the care of patients prior to referral in order to get better care for them once they're in the care of the nephrologist. And getting to this goal really requires redefining how nephrologists and primary care providers work together. So I'll stop there. I'm sure there's no time for questions because I ran over. I apologize. But I'll stick around if you have questions later. Thank you.